Hello, I'm Norbert Gleicher, MD. I'm the Medical Director and Chief Scientist here at the Center for Human Reproduction, and I am very pleased to have with me today David Barad, who is our Chief of Clinical Infertility and Research here at the Center for Human Reproduction. And we have a few subjects lined up for discussion today, David. The first one is a frequent question we hear from patients and from colleagues, of course, which is, does PGT A, Preimplantation Genetic Testing for Aneuploidy, really reduce the risk of miscarriages? And this has been an argument amongst colleagues for quite some time, but I would say that the answer is now pretty clear.
Yeah. Well, I mean, the issue is that aneuploidy is one of the more common reasons why people miscarriage after a natural pregnancy. And it's without a doubt, if you end up doing PGT-A and have a euploid embryo, you'll reduce your chance of having a miscarriage on the basis of aneuploidy. But that's probably only true, what do you think, for about half or so of miscarriages?
Yeah, usually about half of all miscarriages.
So you're still subject to all of the other things that can cause miscarriage, metabolic issues, immunological issues, and anatomic issues. And so all those things need to be evaluated. The issue that we have with using PGT-A to prevent miscarriage is that if you do, what you may really be doing is preventing pregnancies, so that people who are not pregnant don't miscarry. When you have very few embryos, especially if you're a little bit older, there's a big chance that you may not ever have a transfer if you do PGT-A. And the bottom line is that many embryos that have abnormal PGT-A still have a potential of being a viable embryo, a viable pregnancy. And in not doing a transfer, you're basically preventing
even that small chance.
Yeah.
And I think it is also important to recognize that while we have been making these points now for close to 20 years, I would say, even our professional society, the American Society for Reproductive Medicine here in the US and the counterpart in Europe, by now have recognized this statistical problem. And therefore, in a opinion issued by ASRM and its sister organization, SART, Society for Assisted Reproductive Technology, in November of 2024, very clearly came to the conclusion that there's no significant improvement in miscarriage rates from doing PGT-A. Because while, as you said, in some cases it may prevent a miscarriage, it will probably prevent more pregnancies from happening than it prevents miscarriages from happening. And so in total, it really does not make sense to do PGT-A.
I just had the privilege of reviewing a paper from some of our colleagues in which they once again did the kind of experiment that we did in the past, where they compared trophectoderm biopsy to the inner cell mass. Mm-hmm. And once again, they found only about a 60% correlation.
We showed that in our first paper ever.
But they confirmed it again in this paper,
that we published,
which basically means that you're testing the trophectoderm, which is the part of the embryo that will ultimately be the placenta, and you can't test the inner cell mass because there are only a few cells there, and that's the part that should hopefully become the baby. When they tested these embryos that were donated to research, of course, all had abnormal biopsy, 60% still had normal inner cell mass. Yeah.
Of course. And as I said, we showed this already in 2015 in our first paper ever on transferring abnormal embryos. This is just one of the reasons why PGT A obviously doesn't work, and why we do not recommend it, not only for prevention of miscarriages, but also not for any kind of improvements in IVF outcomes. And our opinion has now been officially confirmed by the American Society for Reproductive Medicine, as well as its sister organization, SART. What both of them unfortunately didn't do is to take the next step, which is, if you do something for 20 years that does not give you any advantages, why do it? So unfortunately, our societies have not yet reached the point where they say, okay, it doesn't work, therefore don't do it. We here at CHR have reached that point a long time ago, and therefore we do say, don't do it unless there is a really good reason to do it.
To be fair, if you're somebody who has a history of several miscarriages and you've got 30 embryos that happen to be surviving to blastocyst, and you don't want to go through 30 transfers, you might choose to do it.
Absolutely. Then you have a good reason.
But if you're somebody who has 30 blastocysts, the chances of any one of those embryos truly being aneuploid are relatively small.
Small, exactly right. Yes, and if you have 30 blastocysts, you have actually damn good embryos.
Yeah.
Where every one of them has probably a very high pregnancy chance.
Yeah.
Okay. So in summary, we here at the Center for Human Reproduction really do not recommend routine PGT A testing of embryos for anybody. If you have a very good reason to do it, and there are some reasons, that's a different story. But don't let anybody talk you into it.
And if you truly have a history of miscarriage, you need a careful workup for the other factors.
I'm happy you're coming back to that, because that is really much more important than the basic question about PGT-A as a remedy to prevent miscarriages. A proper workup to understand why people miscarry is absolutely essential. And we are always surprised here at CHR how many patients do not get this kind of a work.
And if you do have a miscarriage, it's very important to get a genetic analysis of the products of conception.
Yes.
Because that's the only way you're going to prove, was this a aneuploid miscarriage or some other reason. If it's some other reason, then you really need a careful workup.
And then the products of conception will show you chromosomally normal ploidy. But even if it's abnormal, if we already are talking about it, it may be biased for exactly the reason you mentioned before. All the studies that have been done over decades were obviously investigating products of conception, and not the fetus, but the placenta. And the placenta comes again from the trophectoderm, as you mentioned, which very frequently, in 40%, even at that early stages, is different from the inner cell mass, which is the embryo. And so even those tests that test miscarriages exaggerate the real incidence of chromosomal abnormalities in pregnancies, because placentas are known until term to contain chromosomal abnormal islands of cells. Okay? So no PGT-A for the average IVF patient who is having a miscarriage. Thanks for listening to us.